Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for tuning into my latest video. So the patient who attended with bilateral fully occluding earwax, and the interesting thing about this particular case was that the patient's ear canals, both of them, were in the left ear at the moment. They're both very narrow, almost collapsed at the entrance, and very bendy and twisty. So whenever you've got a narrow, bendy ear, it's just also a bit more difficult to get access into the ear. So the average ear canal diameter, it does vary as the further you go into the ear canal. At different stages of the ear canal, you've got different heights and diameters. But as an average, the average height of the ear canal is between 0.7 to 0.9 millimeters. And the average width is approximately between 0.6 and 0.8. So the height of the ear canal is greater than the width of the ear canal, which gives the ear canal more of an oval, elongated shape. There are two bends in the ear canal. At the most extreme, the second bend can be at an orientation of 45 degrees. And I suspect this patient has got a 45-degree bend ear canal. The only way we can really know that for sure is if we take an ear impression, so we take a cast of the ear and then we can analyse the impression and the bends. But it was probably one of the most bendiest ears I've performed the procedure in. So not only do we have to navigate the bend in the ear canal, but the entrance, and you'll see in a moment, the entrance is virtually shut. You can see there's not enough space to insert both the endoscope and the zonal suction probe. So it's not an issue with an endoscope, but once you've got the skill and the necessary training, you're able to stretch open the first bend of the ear canal. So the first bend of the ear canal is probably about ½ centimetre into the ear canal itself, and it's cartilaginous, so it's semi-flexible. And what we do, we stretch the ear back and up to not only straighten the first bend so it's more in line with the second bend, so it then makes the ear canal a straight cylindrical tube that goes all the way towards the eardrum. But we also can widen the ear canal by doing that. And once we've stretched the ear, and we actually do that using the endoscope, there's no other, we don't pull the ear back with our hands, or we don't get the patient to do that, we do it ourselves with the endoscope. So we stretch open when we train our clear wax delegates, I always refer to this first part of the ear canal, the cartilaginous portion, as almost like a door flap. So we're lifting the door flap, we position the endoscope into the ear as a door stop, and that keeps the ear canal open and stretched, and we can then gently go in with the endoscope, and we just mitigate the bend. You can just see how bendy this is. So I've removed all the wax, and just going around that second bend, and that's the patient's eardrum fully visible, nice and healthy. You can see from there, that final view, you can just see the angle. And it's the same here, you probably can see the ear canal was just stretched open here to the left. So I've stretched open the ear canal, I positioned the endoscope into the ear, almost as a door stop to keep this cartilaginous portion open and stretched, which then allows me to insert the zonal suction probe into the ear, nice and safely, to remove the wax. So the wax in both ears is a bit hard, a bit dry, and a bit of keratin. You can tell by the reflection we're getting back. When you've got hard, dry wax with some keratin, you do get a reflection back from the light source which illuminates the ear. You can see that keratin actually coating the plug of wax, and it's also at the bottom, it's slightly adhered to the base of the ear canal wall. So it's coming out in more in pellets, this type of wax. It's little dry pieces. So patients still got a bit more. This is actually dead skin, and we're just loosening that from the anterior canal wall. And from there, the actual ear canal is virtually shut, so we have to really stretch it open. And this is what's great about endoscopic earwax removal. It doesn't matter how narrow or twisty the ears are. Once you've got the technique and the skill, you're able to navigate any ear, regardless of its anatomy or the age of the patient as well. So obviously children generally have smaller ear canals than their adult counterparts. So I'm just trying to bring this wax forward laterally. You can just about see some of the cilia, the hair, so we know we're near the outer part of the ear canal. Because it is narrowed, it is kind of plugged in there, so it's a bit of a wriggle. I'm not sure. I may have put some olive oil drops in just to loosen this, which we'll see in a moment. Again, some keratin on this is on the posterior canal wall, the back part of the ear canal. And I'm just trying to go to the root, trying to bring this plug of wax down and forward, trying to roll it. Sometimes we can roll, if the wax is quite dry, and then in a pellet form, we can sometimes kind of roll it out. Just see how narrow that is. You can see how elongated it is. So in America, we call it rugby. In the well, there's two different sports, but a rugby ball compared to a football or soccer ball, it's more round. But the ear canal takes the shape of more of an American football or a rugby ball. It's more elongated, more like an egg shape. So it is quite large, and you can just see how narrow the ear is. I'm just using the Zollner suction probe, and the Zollner suction probe, the internal diameter is 2 millimeters, so altogether it's about 2.2 to 2.3, and it just about fits. So the width of this patient's ear canal, I say it's about 2.5 to 3 millimeters. So I've just put a little squirt of olive oil spray. You can see it's just a bit wet, and that helps just because the wax is quite dry. The oil allows me to get a sufficient suction grip. I'm just wriggling this out. When the wax is quite dry like this, sometimes accidentally, inadvertently, when you're positioning as a suction probe, trying to suction the wax plug out, you can actually push it in, so you just have to be careful. So I didn't use an ear hook initially because the wax was quite deep medial, so I try to avoid using hoops and scoops in the inner 2/3 of the ear canal with the bony part, the sensitive part, and that's the patient's eardrum. It's a textbook eardrum. Patient here significantly better. I hope you enjoyed that video, guys. I am doing a bit of catch up now. I've got loads of videos. Been really busy with both the hair clinic and also Clearwax. I've had loads of training courses, so I do apologise. If you do follow me on Facebook or Instagram, I do try and upload videos now and again, also of the Clearwax training courses. They're shorter videos, some of the procedures, but yeah, do feel just give us a search. The hair clinic. Either on Facebook or Instagram, you can follow me. So if you want your daily dose, or if you want to see videos more regularly uploaded, they are a bit shorter in nature than the ones I upload on YouTube, but please do, feel free to follow me on both those mediums. Take care, guys. Bye.